This exercise deals with the blood. We're going to look at the components of the blood and then at the end how you type blood. Blood, remember, is classified as a connective tissue. The formed elements are the actual blood cells and the matrix would be the plasma. In this case, the matrix is fluid. The formed elements, the cells, you have the erythrocytes, which are the red blood cells, as you can see on this photo. The leukocytes are the white blood cells. As we'll see in just a moment, there are 5 different types of those. They do have a nucleus. They're larger than what the red blood cells would be. And then the little tiny purple specks, those are the platelets. Whole blood, it normally has about 45% erythrocytes, about less than 1% of leukocytes and platelets combined, and then 55% would be the plasma. We look at the red blood cells. They're round, they're biconcave discs. They kind of look like a lifesaver. So the center is depressed. It kind of looks like it's been pushed in. There's no nucleus. The cytoplasm is filled with hemoglobin, and that is the hemoglobin that is responsible for transporting the oxygen and carbon dioxide. The hemoglobin, it's a protein. It has chains, 4 different chains, 2 alpha and 2 beta chains associated with it, and a heme pigment. Iron binds to each heme, and essentially each hemoglobin then can transport 4 oxygen molecules. As you can see in this diagram, an example in A of the hemoglobin, and that yes, each heme group, and there's 1 heme per chain, each heme group can bind an oxygen then, because it's got iron in the middle of it. In terms of clinical manifestations, anemia, if you have hemorrhagic anemia, that means you have an insufficient number of erythrocytes. If there's a low hemoglobin content, that can lead to iron deficiency anemia or pernicious anemia. And you can see on both of those how you can look at a slide and just tell either the red blood cell is a little bit misshapen, it looks a little differently. Another type of anemia is when you have an abnormal shaped hemoglobin. As you can see, the 2 examples here, probably the most common one you've heard of is sickle cell anemia, where the red blood cell is actually misshapen. It looks like a sickle, it's flattened out. Now, if you have too much increased number of erythrocytes, is what you see with blood doping. When you were to look at a sample of blood, you would certainly see, this as compared to the previous slides, there's an abnormally high concentration of the red blood cells. Athletes sometimes do this from the standpoint that the red blood cells do bind the oxygen. If you have more cells, that means you can hold increased amount of oxygen. It increases your resistance and stamina. However, there are some adverse side effects of that, so you need to be very careful about it. The white blood cells are your leukocytes. These are formed elements that do have a nucleus. They are involved with your defense or your immune system. They help to fight against things such as bacteria and viruses, etc. They are grouped into 2 categories: granulocytes versus agranulocytes. As the name implies, granulocytes, when we stain them, it looks like they have granules in them, like someone's dumped sand in them. Agranulocytes do not have these granules. There are 3 types of granulocytes: the neutrophils, eosinophils, and basophils. Agranulocytes, there are 2 kinds, the lymphocytes and monocytes. The neutrophils, the way we would distinguish these is you look at the coloration, you look at whether they have granules. These do have granules inside of them. They're not quite as noticeable as some of the others, but look at the nucleus. Look at how many lobes they have. Look at the shape of them. These are multi-lobed. They function in helping to phagocytize bacteria. So these numbers should go up if you have a bacterial infection. The eosinophils are bilobed, so they have 2 large lobes. The granules look red. They are very noticeable in it. They function to help kill parasitic worms. They are involved with allergies and also the inflammatory response. Basophils are the third type of the granules. If you look at them, it's kind of red and blue. They're darker than the eosinophils are. They're bilobed. Uh, they function in the inflammatory response. They also release heparin, and they do release histamine as part of the inflammatory response as well. Lymphocytes, these are now the agranulocytes. They have a very large spherical nucleus. So it looks like they just have very little cytoplasm as compared to the size of the nucleus. They are involved with your defense system in terms of they are directly play a role with your immune system. The monocytes have kind of a U-shaped nucleus. Once again, this is an agranulocyte. So they have a large diameter with that large U-shaped nucleus in it. They function to help basically later when they leave the circulatory system and go in the interstitial fluid, they become macrophages, which are then responsible for attacking and destroying bacteria and also viruses. To remember which of these different types of leukocytes are more numerous than others, you can use the mnemonic phrase, never let monkeys eat bananas. So the highest concentration of them will be the neutrophils, then the lymphocytes, monocytes, eosinophils, and basophils. In terms of clinical connections, leukocytes, leukopenia, you can see the misshapen cells in the increased number. You know what the ratio should be. Infectious mononucleosis, you can see the misshapen now here are the monocytes. Eosinophilia, you have an increased number of the eosinophils, excuse me. Platelets, these are actually fragments of cells, so they're not true cells. They are involved with helping to repair blood vessels when they get damaged and help with the blood clotting process. So if a blood vessel breaks or tears, you have to plug that hole, otherwise you're just going to bleed out. You're going to hemorrhage. So platelets are involved with helping to repair this. There's clotting factor that's already present in the plasma, and then they're also going to involve substances that are released by the platelets to help plug up that hole. There can be problems with this. So there are different disorders that are involved with when you form a clot when you don't need to. And this would be thrombus. Embolus is when you have a blood clot that moves. It can cause an embolism. If the clot is too large, obviously it can prevent blood flow to the associated tissues, and then they start to have damage there. You can have the opposite problem as well with blood clotting in terms of you have impairment of formation of blood clots. And this can lead to impaired liver function or be due to that. It can also be due to hemophilia. Blood typing, what you're going to be looking at to do blood typing are your erythrocytes and certain markers that are on the surface. The main ones that we look at that for doing a major blood typing would be the surface antigens of A, B, or whether there's nothing there. It's also going to involve the antibodies that are in the plasma. These antibodies help to recognize what is self versus non-self, what's you versus what is foreign. In terms of blood typing, we're looking at anti-A, anti-B, or neither one of those. So you're looking at the red blood cell, what is the marker on it, or the antigen, and then what is the antibody, which would be like an anti-A in this case. For the major ABO blood typing group, you have 4 possible types of blood types. You have AB, B, A, and O. Someone who is type AB blood, and your blood type is determined genetically, they would have the antigens A and B. That's what's on their red blood cell. They do not have any of the 2 major antibodies in their plasma. Therefore, they can receive all 4 types of blood. They are known as the universal recipient. Someone who is type B has only the B marker on their surface of the red blood cell, but they do have the anti-A antibody. They can receive type B blood or type O. They cannot receive type AB or type A because both of those have the A marker on the red blood cell, and when you receive blood, you're receiving the red blood cell. The red blood cell that has a marker would bind, that A marker would bind to the anti-A antibody and cause agglutination or clotting, which can be fatal. A person who is type A has the A marker on the red blood cell and the anti-B antibody. They can receive type A and type O. A person who is type O does not have any marker on the red blood cell, but they do have both anti-A and anti-B antibodies. Therefore, they can only receive type O blood. Because when you receive blood, you are getting the red blood cells, and the red blood cells of someone who is type O does not have any antigen or marker on the surface of it, anyone can receive the type O blood. So if you're type O, you are known as a universal donor. You also have the Rh system when you're dealing with blood typing. This is another type of antigen that may be present. We call it the Rh factor, but it's also called the D antigen. If you have no anti-Rh antibody, you're known as Rh positive. You would have that D antigen. If you do not have the D antigen, then you are Rh negative. You don't have any antibody against it until you have been exposed to it. So this is a little bit different than the others. You have to have a previous exposure. When you do the blood typing, what you're going to do is you would take the blood sample from the patient. You take a slide. You can do this with two. If you just want to do the ABO typing, you need 2 drops of blood. If you're also doing the Rh factor, then you would need 3 drops of blood. You put the patient's drop of blood on the slide, and then you add a serum, anti-A, and then the second one would be anti-B. If there is an A marker on the surface of the individual's red blood cell, it will agglutinate or clot and bind with the anti-A serum. So in this case, what you're looking at is you're adding this artificial anti-A or this artificial anti-B. You're looking for clotting. The only way you're going to see clotting is if that marker is present on the red blood cell. So in the top slide, where you have clotting with both, that means there's both A and B, so the individual, that patient would be type AB blood. On the next slide, there is clotting just with anti-A, but nothing with anti-B, so the individual would be type A blood. The next slide, you have clotting just with B, so the individual would be type B blood. And on the bottom slide, you don't have clotting with either one, so that means the individual is type O. With the Rh factor, if there is clotting, that means the person is Rh positive. If there is no clotting, they are Rh negative. What are some of the clinical manifestations of this? Well, number one, if you need a blood transfusion, certainly you need to have the correct compatible blood type. Otherwise, that blood clotting will occur. As I said, it can be fatal. There is also what is known as hemolytic disease in newborns. This is a condition where the mother is Rh negative, but the developing fetus is Rh positive. If this is her first pregnancy, there is usually not a problem, though you will still be monitoring it. The problem comes into play when the mother has previously been exposed to Rh positive blood and has formed those anti-Rh factors, antibodies. The mother's blood does not mix with the developing fetal blood. However, the antibodies can pass that placental barrier and pass to the fetus and start binding and destroying the blood, and it can have devastating effects. So they will monitor very, very closely if the mother is Rh negative. There is a way that they can deal with this in terms of in the first pregnancy and any subsequent pregnancies afterwards. Usually at week 28, they will give a shot, which is called Rogram, which ties up these antibodies so they cannot cross into the placental barrier. And then they will give a second shot at childbirth.